time for the Delaware Valley's first radio doctor.
On call every Saturday afternoon at 5.
This is Your Radio Doctor with Dr. Marianne Ritchie.
Presented exclusively by Independence Blue Cross.
Your health determines your life, your longevity, and your happiness. Let your radio doctor lead the way with your medical education. Your Radio Doctor, Dr. Marianne Ritchie.
Good afternoon and welcome to Your Radio Doctor. I'm your host, Dr. Marianne Ritchie. Though January is the month during which we recognize cervical cancer awareness, it's an important message all year long. The American Cancer Society produces an annual report called Cancer Facts and Figures. And for 2025, the top causes of cancer death for men and women include lung cancer, followed by colorectal cancer. But if we focus just on women, the top cause is still lung, followed by breast, pancreas, then colorectal, uterine, and ovarian. Okay, so cervical cancer is a little lower on the list, but it's one of those cancers in which screening prevents death, shown by a continued decrease in mortality since the 1970s. And there's a vaccine that reduces the risk of HPV, the virus, which is the number one cause of cervical cancer. And there are simple screening tests that can detect precancerous changes, which can be treated and avoid the whole change to cancer. Joining us today from the Fox Chase Cancer Center in Philadelphia is Dr. Arielle Weiss, where she's an assistant professor of gynecologic oncology. Welcome, Arielle.
Thanks so much for having me. I'm excited to be here.
Oh, well, thank you for joining us. I think it might be good for us to start with defining what the cervix is. You know, you talk to patients, we both do, and sometimes people have a general idea of what a hiatal hernia is or a cervix, but if you ask them to explain it, they probably can't. Maybe we should start there.
Yeah. So, the cervix is basically the lowest part of the uterus. Your uterus is your womb, right? And the cervix is that lower part of the uterus that's within the vagina. And that's where cervical cancer obviously arises.
And I always used to tell my patients that picture a light bulb, and the uterus is the big round part that is the home for developing baby, and that it empties into the channel, or the birth canal is the vaginal canal, but inside is the metal part of the light bulb. And that's the door that keeps your uterus closed to let the baby get to full size. But so the cervix is part of the uterus, but it behaves differently. So when we're talking about cancer, the great thing is we can screen for cervical cancer. We can't screen for uterine or ovarian. We'll talk about that later. But let's talk about HPV, human papillomavirus.
Yeah. So we know that the HPV virus, it is responsible for almost 99% of cervical cancers. So it's really that driving force. And we know that, a lot of women in their lifetime get exposed to the virus. It's something you get through, sexual contact. And so a lot of women will clear the virus. But when it persists and hangs around, that's when it can lead to changes in the cervix that ultimately over time can develop into cervical cancer.
Mm-hmm. And we did a show with a physician named Dr. Abraham Aragones. There's my practice at my accent there. He's from, Hackensack Meridian Health. He had been at Weill Cornell and Sloan Kettering. And he gave a great talk on HPV and all of the important elements to it. It's the most common sexually transmitted infection in the U.S. And we learned at that time that between the ages of 15 and 45, about 80% of young people will have HPV at any given time. But you just made a really important point that I want people to hear. Most of the time, it does not turn cells into cancerous cells, but we still want to stay ahead of it because I don't want to be one of the few that does have it. And it's passed with sexual contact, but even kissing and skin to skin. So please, listeners, think about getting your children vaccinated. Warts are probably the most common outcome of the viral infection, but cancer, no thanks. So let's talk about the screening tests that are employed. The Pap smear and HPV testing, how are they different?
Yeah. So the Pap smear essentially is looking at the cells of the cervix. And so the way we get our Pap smears is, during a routine gynecologic exam, the speculum is placed in the vagina. We view the cervix, make sure it looks normal. And then we collect some of the cells from the outside of the cervix. Those are the ones that are exposed, right, to the outside via the vaginal canal and are the most at risk of having that HPV virus. So we collect those cells, and the pap smear is looking at the cells under a microscope to say, do they look normal or abnormal? And then there's separate testing that's done to look to see if the virus is present, the HPV virus itself. And so, traditionally the combined testing that we do together looks both at the cells and for the presence of the virus.
Mm-hmm. So if people are wondering, the word PAP is short for Papa Nicolau, the doctor who came up with that test, yes?
Yep.
Years ago. Do examining doctors, be they family medicine docs or gynecologists, routinely do both, or do some people do one or the other?
So a bit of it depends on your age, right? So the recommendations right now is, we start pap smear testing, which is just looking at the cells at age 21. And then it depends on the resource that you go to, but, gynecologic societies recommend that starting at age 25, you can incorporate that HPV testing. The reason we don't do that HPV testing in younger women is we know that exposure risk is high, but the clearance rate is also high. So we really want to start catching it when it's either, someone who maybe had it and hasn't cleared it, which is when that risk is really the greatest from the HPV.
So let's talk about risk factors, because for starters, if you have a normal immune system, most of the time, as you've said now a couple of times, so important for people to hear, your immune system is able to clear that HPV and you're free of any danger of cancer. And there are different strains of HPV. I guess we can talk about that a little bit later. But what are the risks for cervical cancer?
Yeah. So, obviously HPV is the biggest one. And then, if you're immunocompromised, you have a harder time clearing that infection. So those people who are immunocompromised, either, they had a kidney transplant, they're on immunosuppression, or they have HIV, those people are at increased risk and require actually different screenings. And then having multiple sexual partners, that increases your chance of exposure to the virus. So that increases your risk. There's some thought that infection can as well. Other sexually transmitted infections. Mixed data on the birth control pill. Some of that may just be, lack of use then of condoms. And, condoms can actually protect from acquiring the virus. So that may be kind of where that comes from.
I think that's really important, Arielle, because you'll see data, but it has to be interpreted. It's not that the medication that's being used to prevent conception causes your cervical cells to go awry, but it leads to different sexual activity, probably, as
exactly.
you say. Mm-hmm.
Exactly. We know that women, of lower socioeconomic status, lower access to care, healthcare deserts, those are big risk factors for cervical cancer, just from, lack of screening and lack of access.
Mm-hmm. Well, I think, too, when you mention sexual activity, multiple sexual partners, the more contacts you have, obviously, the more likely that you're going to connect with HPV. But I was reading that it's more likely to occur in those under age 18, that they have a higher risk. I don't know how valid that is and what you've seen. And the other thought is you might only have one partner, but maybe that partner has had multiple contacts. So
exactly,
we're trying to just share this so people think about before they act.
Yeah, and I know a lot of women, who get diagnosed with HPV, they wonder, can my partner get testing? Is there anything my partner can do? And that's, the one unfortunate thing. There is no good testing for males. But that's why it's so important for females to get this testing to monitor for themselves, for the HPV and the sequelae from that.
Family history, there probably is not a genetic predisposition, but maybe family members end up having similar lifestyle factors.
Yeah, I think that's probably what it is more so. There's no proven genetic link for cervical cancer the same way that there is for other gynecologic cancers. But yeah, absolutely. It may just be kind of practices, circumstances, that sort of thing that may lead to kind of a family history of
right.
it.
Young at first full-term pregnancy, women who give birth before the age of 20, but maybe because they were sexually active at a younger age, exposed to the virus, and it's had more time to attack them, yes?
Exactly. Exactly. So earlier, sexual debut, as we call it, can have that. And that goes hand in hand with early pregnancy. It's really the virus, the longer time that it has to be exposed to the cervix and to integrate and cause those changes, the more likely you are for the cancer to develop. So time is definitely a big factor for that.
Well, the other factor that I'm sure you don't see so much anymore, and again, for our listeners, Dr. Arielle Weiss, our guest today, is a gynecology cancer specialist. So oncology, I think most people realize that's a cancer specialist. So you see people, for the most part, after they're diagnosed. You're not a gateway, a primary care gynecologist or family doctor. You're seeing women are already diagnosed. But this is probably old news for you. But when I was in medical school, one of the stresses that we learned about was DES. It was a drug used from about 1938 to 1971 to prevent miscarriage. And we're finding that women whose mothers took DES to prevent miscarriage, that they have a higher risk of cervical cancer themselves, yeah?
Yeah, and with them, really, the another big risk is vaginal cancer, and in particular. So, luckily that hasn't been used for a long time, so it's getting less and less that we're seeing women who have that exposure. But that is a drug that was historically used and luckily no longer is, but has been linked with risk of cancer, actually, especially vaginal.
And we do put a lot of emphasis on women in lower socioeconomic situations because of access to care. But I know as a woman in gastroenterology, so many of the I think I was one of the first women to practice GI in Philadelphia, so I would get so many referrals from the gynecologist because a patient would see them with belly pain or something that'd say, well, everything in our world looks good, go see Marianne. And what I found was that so many women, I think statistically, women are more likely to see the doctor or go to doctor visits, whereas men are more likely to get screened for colon cancer. That's the GI world. But is it because women have menstrual periods and pregnancies and they often look at their gynecologist, their primary care doc? What I'm leading up to is, yes, we really have to put more emphasis on going out and reaching the women who don't have a paycheck or lesser education. But guess what? Busy women who do have a job and do have an education, have children and elderly parents, we're not taking care of ourselves either. I can't tell you. Of course, you do too.
Absolutely.
I see so many women who say, I got my mammogram because I'm in and out. There's no sedation or IV or PrEP, done. Plus all the emphasis for all these years, and all the pink campaigns have been fabulous. However, so many women, and you as a gynecology cancer specialist, you have to see the same thing. Mammogram and done. Am I right about that?
Yeah, absolutely. Absolutely. And, I think a lot of it is the gynecologist, exactly as you said, people go during their childbearing years, they see them as their primary care doctor. And then when they're done with that phase of life, it's kind of, it's not a comfortable place to come visit. We understand that. No one loves to get a pelvic exam. So I think a lot of women, put priority on other things, which is, very easy to do in everyone's busy life. And so just really emphasizing the need for continued gynecologic care throughout, your lifetime.
Exactly.
It really doesn't just end with childbearing.
But I want to repeat so listeners take this message as well. It's really important to note that most women who are infected with HPV, human papillomavirus, do not develop cervical cancer. But we are begging you to get your regular GYN visits, cervical cancer screenings as directed by your doctor, either Pap test and or HPV, to help detect and prevent cervical cancer early on. Let's take a little break, and when we come back, we're going to talk about the screening guidelines for cervical cancer with Dr. Arielle Weiss from Fox Chase Cancer Center.
Thanks for listening to Your Radio Doctor with Dr. Marianne Ritchie, exclusively presented by Independence Blue Cross. If you have a question for the medical mailbag, just send a note to doctor@yourradiodoctor.net.
Welcome back to Your Radio Doctor. We're learning so much about cervical cancer and screening and the risk factors with Dr. Arielle Weiss from the Fox Chase Cancer Center. Arielle, thanks again for being here. I'd love to talk about the screening guidelines for cervical cancer because, as we said earlier, I don't do gynecology screenings. And for the most part, I guess you don't, but
anymore.
Well, because you're a cancer specialist, yeah. But that has become such a confusing issue for so many women because they say, well, I just had a normal pap or I don't have HPV, so I don't have to see my doctor for 3 years. Oh, nay, on the ixnay, you still should go once a year. And why is that?
So, yeah, I mean, that's a really great point. There is a lot of confusion, and I think a lot of women equate pelvic exam with pap smear, but they're different. The pap smear, as we said, is that screen for cervical cancer, checking those cells of the cervix. But it's important, even if that's normal and you can go 3 or 5 years, and we can talk about kind of the recommendations, a pelvic exam is still really important because it's also visualizing the cervix to make sure you don't see anything. It's feeling the uterus, make sure it feels a normal size. It's feeling for the ovaries. Are those normal? And that's the best screening that we have, really, to detect something within the pelvis, because the pelvis is so good at hiding things as they get bigger. As we know, pregnancy can hide itself for a long time because you don't notice things in the pelvis. So that pelvic exam, that annual visit, is really important to continue. Even if the pap smears get spaced out, you still have to go see your gynecologist for those annual exams between.
Plus, who's going to do your breast exams? The American Cancer Society, the different national guidelines say they're encouraging women to shy away from self-breast exams. Am I right about that? Because of so many false positives, meaning you feel a little something, then you go through biopsy and all that, which is not without risk, I guess. And it's a false alarm. Personally, I'd rather have the false alarm, but I don't write the cancer screening guidelines. But the other thing is, I always remind my patients that the word screening means a test that can give us a jump start and find cancer at an earlier stage because you don't have symptoms yet. So we do screening, means a patient has no symptoms, meaning they don't feel anything that they report, and no signs, nothing that your doctor finds when they examine you, like an abnormal looking cervix or a mass in your belly.
Yeah.
If a person has abnormal bleeding, even especially if they're postmenopausal, or abnormal discharge, pain in the pelvis, or if you see the cervix looks abnormal, that's a diagnostic test, right?
Yep. Yeah, exactly. Based on an abnormality, as opposed to exactly like you said, screening is everything looks and seems normal. And then we're looking to make sure there's nothing microscopic early on that we can detect.
So you mentioned age 21. Is that when you start with somebody who's at average risk, meaning they don't have DES in their family history, they might not have immunosuppression? Let's talk about that.
Yep, exactly. So we recommend starting at age 21. Regardless of the time that you start becoming sexually active, 21 is a good time to start. And that is just the cytology screening. So that's just looking at the cells, again, because that HPV virus, when you're younger, you have a higher chance of clearing it. So it's really, the recommendations that we follow are similar to the American Cancer Society. And we have our society of, colposcopy and cervix and the gynecology guidelines, basically. And they recommend HPV screening starting at 25.
And then after, say, 21 to 29, you're going to do the PAP about every 3 years?
Yeah, so if you're just doing the pap smear without the HPV testing, as long as it's normal, then you can space that for every 3 years. When you add in the HPV with the cytology, that's what we call co-testing. If those are both normal, meaning the cells look normal and there's no presence of the HPV, then you can space that to every 5 years. But that wouldn't start until age 25.
Oh, right. And then did the guidelines change after a certain age, like maybe 30 to 65? So
historically, it used to be 30 was when HPV testing was started, but the guidelines had been updated. I believe like 2019 is when we updated to bring the HPV into age 25. But traditionally, it was age 30 to 65 that you would do the co-testing, meaning both the cytology and the HPV.
And we don't expect people to be listening and memorizing all these fine details, but it's just to say there are really clear guidelines for your doctor to follow. And again, don't think that if you've had a normal test result from your HPV test and they say, well, you don't need this scraping of the cervix for cells, and it's not scraping it. It looks like a little tiny popsicle stick, a little wood stick, and simply by soft rubbing of the cervix, we get hundreds of cells to examine, so maybe more than that. And so easy test, but don't think that for the next 4.9 years, you shouldn't go back. We said breast exam. And how about if you do the PAP's okay, but you have ovarian cysts or a fibroid in the uterus that you might not feel, you might not understand why you have heavy bleeding. That may be palpated when the doctor examines your belly, yes?
Mm-hmm. Absolutely. That's a great thing, is the exam can pick it up before someone notices or becomes so large that they notice. Yeah.
So we talked about the people who are at higher risk. Do their screenings, are they started at an earlier age? Somebody who has immunosuppression from, say, lupus or inflammatory bowel disease, they're on an immunosuppressant med, or they have HIV or an organ transplant. Do they start at a younger age, or do they see their docs for these PAPs and HPVs more often?
So their recommendation is to start when they become sexually active. So that if that is sooner than 21, that is when they come in for their screening. And typically for those patients, when you first get started, you want to do yearly. And then if they're normal, you can space them to 3 years, but we typically don't space them out to 5 years.
And at what age do you stop screening? Because I know, say with colorectal screening, we say a person gets to a certain age, and if they've never had a polyp or anything, we say maybe let it go at 75 unless they develop symptoms.
Yeah. So the recommendations, if you've had regular screening throughout your lifetime and you've always been normal, is that you can consider stopping at age 65. I think a lot of that is a discussion as well, with your provider. As we're living longer, 65 almost sounds a little bit young.
Baby.
But right. But if you've been normal, because cervical cancer is a slow growing cancer and your risk factors, at that time are usually less. That is a time that you could consider stopping if you've been normal and if you've been regular. So
you mentioned earlier vaginal cancer. Is that a partner of cervical? They're separate risk factors, I know, but let's say somebody's had a hysterectomy for fibroids for a benign reason. They don't have any increased risk of vaginal or cervical cancer from what I'm reading, right? Yeah, the main thing to consider in those situations is what has their prior cervical cancer screening been, right? So if they have a known high risk or, precancerous lesion, basically, that was high grade, then we actually recommend continuing doing pap smears on the top of the vagina, because that HPV virus, while it primarily lives within the cervix, can affect the vagina, can affect the vulva even. Wow. So if you've had a high risk precancerous lesion of the cervix, even if it's been removed and now the cervix is gone, we do recommend screening actually for 25 years after that treatment. Good to know, because I think people can't get hung up. Well, let's say it right now. HPV, we said, is the number one sexually transmitted disease, but it also, which we learned in the show we did, 99% of cervical cancers, by 2030, it is projected to cause more oral, pharyngeal, and tongue cancers than cervical cancers. It is just a beast. It's the blob taking over the diner. And let's talk about that for a little bit. If a woman has the vaccine, or a woman or a young fella or gal has the vaccine, it protects us against certain strains of HPV, but not all strains, yes? Correct. Yeah. So the most up-to-date vaccine right now covers for 9 of the most common HPV strains. So the ones that we know are most likely to cause cancers or most likely to cause anogenital warts. But it's not all of the strains. There are many, many strains of HPV. So it's not 100% protection, but it is for the most commonly caused virus strains. Mm-hmm. So the take-home message there is, even if you get the vaccine, you still have to get regular PAP and or HPV screening, because it could be extra sneaky. So if a person has an abnormal test, a PAP smear, depending on how abnormal the cervical precancerous changes are, that might lead to more of a biopsy or colposcopy. Can you explain quickly what the colposcopy is?
Yeah. So, if we see abnormalities on the pap smear that are of a certain degree, then we recommend what's called a colposcopy. And that's basically us looking at the cervix under a microscope, because a lot of times we can see microscopic abnormalities in the cervix that can lead us towards diagnosis of a precancerous lesion or a cancerous lesion. But always the goal is to catch things early. And so a colposcopy is where we look at the cervix closely with a microscope. And if anything looks abnormal, we take biopsies of that. And all of this is done in the office, so it's not something requiring the operating room. It's done in the office to just get a better view of the cervix.
Mm-hmm. And a biopsy is a bigger piece of tissue than just scraping the surface of the cervix, so it kind of tells you what's happening in the neighborhood of an area that looks abnormal.
Yeah.
And the other really good thing is if you have an abnormal HPV test, a lot of times you'll say, let's check it again in a year, because maybe you'll be fortunate that it's one of those incidents that the HPV is cleared by immune system 90% of the time or so. They just go away.
Exactly.
Good
exactly. So so if those cells are normal and it's just HPV, it's the first time you've had it, the HPV being positive, then we just say come back in a year and let's see if that HPV is still there. Maybe the body takes care of it on its own.
So the vaccine, HPV increases risk for 6 cancers, and we've said cervical, and I guess that's why in the beginning, when the vaccine became available, it was let's vaccinate all the girls.
Right.
But when you think about it, if they're sexually active, the boys then help to transmit it from person to person, etc. And what we're learning is, we already said that there will be more throat cancer, mouth, pharynx, throat, tongue, by 2030 than cervical. Not that it's a contest, they're both bad, but the big ones are cervical, and then anal cancer in men or women, cancer of the penis, we said the mouth and throat, vaginal and vulvar. So lots of reasons to get children. So we say ages 9 to 27 are the big ones, but they've extended it to 45. Let's talk about that.
Yeah. So, the recommendation is you can start getting the strain at age 9. And we know that the younger you are when you get it, the better protection it affords, mainly because you haven't had the exposure yet. And so actually, if children get it, most commonly 9 to 11 to 14 is really what we shoot for. And they can actually just get two doses of the vaccine. When you're getting it later, sometimes you require 3 doses, and that's just to help your immune response. But, even if you're someone who's 25, 30 years old, you never got the vaccine, even if you have an abnormal pap smear, you are eligible to get the vaccine up to age 45. So don't, let the time frame necessarily restrict you if you're older and haven't received it, because it can still provide protection.
And there are different types of HPV. So maybe somebody's had HPV and they've had genital warts, still get the vaccine, because we want to prevent the cancer knocking on your door. Exactly. And as you said, the vaccine, the most generous one, protects against 9 strains, but not all strains. So even if you have the vaccine, it's not a pass. You still have to get tested on a regular basis, because it doesn't protect against all strains of HPV that can lead to cancer. And the other take home is it doesn't protect against other sexually transmitted diseases.
Correct.
Especially kids exchange information, say, hey, I got the shot, I'm good. And they put things in to make themselves relax about things, not intentionally, but I guess we all do that to a degree, yes?
Yeah, absolutely. But it's really just that protection for HPV. So, still using good, safe sex practices is important.
Let's take a little break and hear about this week's champion. And when we come back, more on gynecologic cancers with Dr. Arielle Weiss. And now for your real champion. I call this segment, Thank You, Police Officers of Lower Merion Township Police Department. Police officers willingly sign up for a job in which they risk their own lives to keep us safe, whether it's tracking criminals, maintaining traffic safety, or administering CPR in an emergency. But what many people don't realize is that aside from catching bad guys, our officers spend a tremendous amount of time enhancing public safety in other ways. Recently, I bought a new infant car seat for my new grandson. I remembered that 5 years ago, with the arrival of our first grandchild, I took advantage of a wonderful service provided by the Lower Merion Township Police Department. As a free service, an officer will install the base of an infant or child's car seat. So I called the police department. The officer set up an appointment for the very next day. In clear detail, the officer demonstrated how to install the base, then gave specific instructions how to secure a child in the seat, and reviewed the steps of removing and reinstalling the base if you ever move it to another vehicle. Well, you might think, how hard is it to put the base in and then add the car seat? Well, guess what? 8 out of 10 car seats are installed and used incorrectly. This is a free service provided by the police department, so your infant or child has a seat that's installed correctly and that you know how to safely secure your child in the seat and maintain that safe position. Vehicle crashes are the number one cause of death in children ages 1 through 13. Protect the most important people in your life. This is a free 20-minute appointment that can reduce injuries in an accident or even save your child's life. Additional helpful services for the community include Lock for Life. It's a program in conjunction with ElderNet of Lower Merion and Narberth, and it's administered by the Lower Merion Township Police Department. A key to your home will be stored in a secure metal storage device, like a realtor's lockbox, near the entrance of your home. The access code to the lockbox will only be available to police, fire, and emergency medical service personnel to access your residence in the event of an emergency when you're unable to open the door. It's available for Lower Merion and Narberth residents age 55 and older, or younger disabled persons who live alone and or have major medical problems. Again, no charge. There's also a prescription drug take-back program. Medicine take-back options are the best way to safely dispose of most types of unneeded or expired prescription and over-the-counter medications. There's also a Citizens Police Academy where you can learn firsthand about police officers and how they train their dogs and prepare the SWAT team. Police officers make it a priority to engage with members of the community they serve. They visit public and private schools to offer important tips about crime prevention along with materials. And to further create a positive connection, they work with the National Night Out organization. During the first week in August, in the Wynwood Shopping Center parking lot, there are carnival rides for kids, live music, and a chance to meet first responders from the police department, emergency medical services, and more. So a special thank you from me and my grandson Patrick for keeping him safe. And a special shout out to all police officers, especially those in the Lower Merion Township Police Department. We're grateful for their bravery and dedication and salute them as your real champions. Welcome back to your Radio Doctor. We're here with Dr. Arielle Weiss from the Fox Chase Cancer Center. Arielle, we've learned a lot about screening for cervical cancer and the risks and how we follow through to make sure we're giving people the best opportunity and the best chance to avoid cervical cancer, especially from that nasty HPV that's so omnipresent. Let's talk a little bit now about endometrial or uterine cancer and a bit about ovarian cancer. Are there screening tests for those cancers?
So unfortunately, there are not. There's been lots of studies trying to say, is there ways we can screen for these, especially in those patients who have increased risk from a genetic standpoint. But there's no great way to screen for these. So I think that's where really the importance of staying with your annual visit, seeing your gynecologist, talking through any new or abnormal symptoms or changes you're having is really where we're going to be able to pick up these types of cancers.
Mm-hmm. So again, if you're just tuning in, a pap smear looks for abnormal cells in the cervix, which is the lowest part of the uterus. The HPV test looks for the virus called human papillomavirus. That's the number one cause of cervical cancer. And if you hear, hey, you don't need a pap smear for 3 years or whatever the time frame is, don't think it means don't come back to see me on a yearly basis, because that's a time when you pause, take the time to chat with your doctor who asks you questions like, do you have any belly pain? I wouldn't think to tell you that, but yeah, once in a while I do. Or when you pause and think about yourself and really ask the hard questions, I forgot to mention it, or The American Cancer Society and guidelines encourage women to report vaginal bleeding, discharge, spotting, any of those issues to their doctor. Don't think because you had a normal pap, you're good to go. Yes? That's a common mistake people make.
Absolutely. Yeah. And I think, so from like an endometrial or uterine cancer standpoint, right, that's a cancer that arises from the lining of the uterus, kind of that inside part of the uterus that normally you shed every month with a period. And so that's where the big symptom for people to know about for that cancer is, bleeding after menopause. That's never a normal symptom. Even a little bit of light spotting, pink or red that you see, that requires an evaluation because that's abnormal.
Mm-hmm. And so important then to have a regular pelvic exam because it's hard when you feel somebody's belly, unless they have a really enlarged uterus, you're the pro, or a big fibroid. Yeah. You might not pick up early cancers, but you're not delaying the finding of cancers that have already made their mark there. So women at increased risk for uterine, well, who's included there?
Yeah. So the biggest risk for uterus cancer, kind of the traditional uterus cancer, is extra estrogen. So that's kind of the driving force is a presence of excess estrogen. And so, that can be obesity. That can be, you started your periods early and you went into menopause late. You have that presence of estrogen around. Other things, not having children, infertility with PCOS, extra estrogen around, tamoxifen use. A lot of breast cancer patients get placed on tamoxifen. That can be a big risk factor for endometrial cancer, or hormone replacement therapy. If you're on that without a progesterone, so just estrogen alone,
yes,
that can be a really big risk factor as well.
Well, I think too, I didn't mean to interrupt you, but when you say never having had a baby, when you think about it, if you're expecting a baby, your estrogen goes into that process and it's not around to feed breast cancer or uterine cancer, so it's preoccupied. It's like, go do something else. Don't start cancer in the uterus or the... I wonder how infertility leads to increased use for uterine.
Yeah. So, if you're someone who doesn't ovulate every month, right? So that lining of, so the menstrual cycle, essentially what needs to happen is every month that you ovulate an egg, right? And if you get pregnant, great. If you don't, then the lining of the uterus sheds. And there's estrogen leading up to that release of the egg that builds up the lining of the uterus every month. And when there's no pregnancy, that's the period that you shed. So if someone isn't having regular periods or ovulating and that lining of the uterus is not being shed with a period, so if you're missing your periods 2-3 months in a row without having a period, that lining can build up and those cells have time to become abnormal. And so that's really what that driver is from the infertility standpoint. Not necessarily the infertility drugs, although that, that can be a mixed picture, but it's that lack of a period and that having the lining build up without shedding it every month.
That's a great explanation. And you mentioned that if somebody's on estrogen without progesterone, it's not being challenged by the cousin of progesterone. But you would figure that doctors who prescribe those meds would know that. We're saying that to people who go on the internet and order medications. Please do not trust. Don't be Dr. Google for something like that. And that's a whole nother show, really. But Lynch syndrome. When I was a fellow in GI at Sloan Kettering, we dealt with Dr. Henry Lynch. He was in the Midwest. And he was the doctor who realized that if you look at a family tree and you see multiple members that have either colorectal and or endometrial uterine cancer, so colon and uterine cancer, to look for this syndrome that's polka dotted with one or both. So if a listener has a relative that's found to have the positive genetic test, or if they know that they go to Thanksgiving and they learn about the family tree, get tested, because Lynch syndrome, endometrial uterine cancer skyrockets. Yes?
Yeah, absolutely. So if you have a genetic mutation that is within that Lynch syndrome family, your risk of uterine cancer goes up remarkably, as it does for colon cancer. So really important to get that screening. And then we can do, preventative measures to screen, and we can do preventative surgeries, to remove the uterus and prevent the cancer from forming in the first place.
And you say the preventative testing you can do, you can go ahead and pretty easily, nothing's easy, but you could get biopsies from the lining of the uterus beginning at age 35. This is coming in a lot of, not everyone, but hey, listen, if they told me to have a mammogram once a month, but my family history is polka dotted with breast cancer, I'd say fine. I'd rather go through a little hassle than go through chemo and radiation and surgery. So same here.
Yep.
Ovarian cancer. Again, there are no screening tests for ovarian, but we do know some women are at high risk.
Yeah. Ovarian cancer has been quite challenging in that way because it does tend to be kind of silent for a long time until it's spread and metastasized. So, if you have a family history of breast cancer, ovary cancer, pancreatic cancer, those are the patients that we can get genetic testing on to see if they're at that increased risk, to know and try to minimize that risk for them because there is no proven screening methods.
Yeah. Well, and I think if we talk about Lynch syndrome, which you said colon and uterus go together, among other cancers, but the BRCA gene mutation, which is maybe only, better than I, maybe 2% of breast cancers. And it's interesting when people get diagnosed with breast cancer, and, in a family member, they say, oh, there's no BRCA. That doesn't mean you get a pass. Maybe it's a gene in your family yet to be detected. But what you can do if those genetic changes are in your family, or if you have a strong family history of breast and ovarian, right? The test you might do would include what? To really keep an eye on those women.
Yeah. So the testing that we recommend if you're found to have a gene that increases your risk, nothing is proven to increase survival. So a lot of it is, with counseling and consideration. But what we can do is ultrasounds of the uterus and the ovary. So, a pelvic ultrasound. And then there's a blood test called a CA-125 that can be done. And that can be an early marker of ovarian cancer. It's not a perfect test. And there, of course, are times that between testing, as with every screening test, a cancer can come up in between. But it's the best thing we have right now. And so that's kind of where we are in terms of a screening for those high-risk patients only, really.
And you're right, and that's what you were saying earlier, that we don't want, the recommendation out, don't do self-breast exams, will be over-testing, which leads to risks. And same as this CA-125 blood test, when it's helpful, but it can be elevated because of just inflammation in the pelvis, which we call pelvic inflammatory disease or endometriosis. So if you do have an elevated test, don't panic right away. Easy for us to say, right? So still, as you say, even if we do not just a pelvic ultrasound, but a transvaginal, put the probe in because ovaries are so nasty because they're floating in cyberspace because, I always tell my patients, your stomach is just a little pouch. This whole area between your rib cage and your hips is the abdomen. And that's a big cave. That's the home for your GYN goodies and your colon and your pancreas and all those things live in there. And if you get a cancer in, say, your pancreas and it presses on your duodenum, then you might lose your appetite or you start to lose weight. But the ovaries can have a pretty big tumor before you get other symptoms. Whereas uterus, it trickles blood, or cervical discharge. It's tough, right?
Yeah, and a lot of the symptoms that women have are really subtle, and so it's easy to kind of attribute it to something else, Oh, I had a little bit of constipation, or my bowel movements were a little bit different, but they're better now, or I had a little bit of bloating, but now it's gone away. And so it's that's really what makes it challenging, is that it's subtle symptoms initially that can very much be attributed to something else. And so really trying to be in tune with your body and reporting these things, right? When you go to see even your family doctor, your primary care doctor, saying, I had this time, I was a little bloated, or I noticed my bowel movements are a little bit different. Or I'm urinating a little bit more. Sometimes if a cyst on the ovary gets big, it presses on the bladder.
Yeah.
So it causes a lot of kind of bystander symptoms, but that are very subtle in the beginning.
But so that's a message for our physician listeners as well, because you'll see a patient with constipation and they have colonoscopy and say, you're good to go. It's nice and clear. but we still haven't answered why a 55-year-old woman who has had a nice cooperative assembly line, evacuates, has bowel movements on a regular basis all the time, and all of a sudden she doesn't. It might be something other than an uncooperative colon. It could be pressure from a mass in the uterus or an ovarian mass, and you can't stop there. You might do a CAT scan or a pelvic ultrasound and look for another critter. Mm-hmm.
Yeah, exactly. And that's where a pelvic ultrasound is a simple thing to get. It's a quick study, but it gives us a really good look at the ovaries, the uterus, to say, are those normal, or is there something going on there that's attributing to the symptoms? And it's those times that women report those symptoms early and get those scans that we have the best chance of catching things early.
Pelvic ultrasound, inexpensive, non-invasive, no radiation, and sometimes ovarian cancer causes fluid called ascites that can cause that bloatedness that you refer to. And the sooner we get and identify a problem, the more likely we can have a better result. Let's take a little break and we'll be back for our wrap-up. Welcome back to our final segment of Your Radio Doctor. January was Cervical Cancer Awareness Month, but every month should be Gynecologic Cancer Awareness Month. We're seeing that with pap smears, which looks for abnormal cells of the cervix, or even HPV, the virus, human papillomavirus, we can test for that if a woman is told, well, gee, you don't need a pap smear for another 3 years or 5 years, depending, that translates into, I don't have to see the doctor for 3 years or 5 years. Let's talk about that again, Arielle, Dr. Arielle Weiss from Fox Chase.
Yeah, I think, really the take-home message is, it's important to get your screening done, but then it's important to also, stay current with your pelvic exams and your gynecologic exams. The pap smears have been great, reducing, cervical cancer, all in all, with the combination of the HPV vaccine, but knowing the importance of staying regular with gynecologic exams so that your doctor can help you identify if there's new symptoms going on that could signal something else, and really stressing that importance. Mm-hmm.
What's the biggest message you'd like to share with listeners?
I think the biggest thing, like I said, it's staying regular with your gynecologic care. It's easy, I think, to fall into the trap of, I'm done my childbearing, I was normal then, I don't need to see my gynecologist anymore. And I really just stress that it's important to stay current and stay up to date with your gynecologist to make sure that nothing is coming up that you're not aware of, or that you kind of are pushing to the side because it's subtle.
Mm-hmm. And if you do notice symptoms of bleeding, especially after you've gone through menopause, again, if somebody says, well, you had a normal pap smear or HPV test, they only look at cervical cancer. Bleeding can be from the lining of the uterus. And if you have abnormal bleeding or pain in your pelvis, change in your bowel habits, tell your doctor. Don't rest on the laurels that one little part of your picture, the pap smear, was normal. No, it only tests for cervical cancer.
Exactly.
Is there a website that you refer listeners to or your patients that you find really helpful?
Yeah. I think the American College of Obstetrics and Gynecology is a great evidence-based, data location with education for patients. And it really helps you understand, I think, the guidelines too, to know what you need, what symptoms are normal or abnormal. I think that's a very, reliable resource. And then, American Cancer Society, the CDC, those are great websites to look at to figure out, what screening should I be having, what's normal, what's abnormal.
So I'm going to repeat them. The American College of Obstetrics and Gynecology is ACOG. Yes, mm-hmm. ACOG. People can Google that. And I know the American Cancer Society website is cancer.org. And then you mentioned the CDC, which really, I have to say, all of the websites you mentioned explain in such great detail in really clear, helpful language. And we'll review things we talked about today, including the difference between PAP and HPV testing, risks for cervical, risks for ovarian and uterine. Dr. Arielle Weiss, thank you so much for joining us. We learned really important distinctions among these three cancers, and hopefully listeners will be ahead of the game and see their gynecologist every year.
Thank you so much for having me. It was great to be here.
Thank you for listening to your Radio Doctor every Saturday afternoon at 5 here on Talk Radio 1210 WPHT. Listen to all of our shows at your convenience on Audacy.com, AUDACY. And thanks to our exclusive sponsor, Independence Blue Cross, for their continued support. Now watch every show on YouTube. Just search Your Radio Doctor and please subscribe to our YouTube channel. It's free and it's easy. Go to YouTube, search Your Radio Doctor, and please click on subscribe. It's free. Well, our listenership continues to grow, so we invite you to partner in the show as a sponsor. We'll help you share your message. Just contact me through email. Send a message to info@yourradiodoctor.net. info@yourradiodoctor.net. Join us as a sponsor. February is Heart Month. We're looking forward to hosting 2 shows in the theater with a live audience here at the Odyssey Studios at 2400 Market Street. Join our audience on Tuesday, February 11th. That's this coming Tuesday, February 11th. 2 shows. The first one's at 3 o'clock, so we ask you to arrive by 2:30. We'll discuss Go Red for Women and women's heart disease, and then focus on heart disease in children and the absolute need for parents, daycare workers, and all caregivers to learn CPR for children. This coming Tuesday, February 11th, right here at 2400 Market Street. Tickets are free, but you need to register. Visit our website, yourradiodoctor.net, for details. That's yourradiodoctor.net. Happy Super Bowl weekend. We hope you enjoy your watch parties and that the post-game celebrations are fun but safe. We continue to pray for peace in our world, peace in our beloved country, in our families, and in each of our own hearts. This is your Radio Doctor, Dr. Marianne Ritchie, wishing you a happy, healthy, and safe week with the ones you love, and always here to remind you that your health is your wealth.
Thanks for listening to your Radio Doctor, Dr. Marianne Ritchie, presented exclusively by Independence Blue Cross. To contact Dr. Marianne and to listen to today's show as well as past shows, visit yourradiodoctor.com. This program is paid for by Your Radio Doctor, LLC. All opinions or statements expressed on this program are solely those of Your Radio Doctor and their guests and do not reflect the opinions of WPHT or Odyssey. Today's program has been pre-recorded.